one more thing. So this was what I was supposed to moderate about the virtual tumor board on immunotherapy in lung cancer. Can we go to the next one? So my first question to everyone is, just stay over here. Immunotherapy non-small cell lung cancer, hope or hype? Suresh, do you still have some doubts?
I think absolutely no doubts that it is a big hope, and I think the what you call the amount of hope is increasing day by day as we explore newer and newer indications and territories for immunotherapy. So from my side, it's a big thumbs up to immunotherapy, no doubt.
Absolutely. So all thumbs up, no Sprite, no Limca, no Pepsi, no Coke, only thumbs up for you. Fantastic. Can I have the next one? Okay. Dr. Deepak, do you think the glass is half full or half empty?
So, sir, definitely immunotherapy is adding to one of the important treatment options, and possibly why we all are excited is because of the tail and the prolonged responses that we see with immunotherapy. I think that is the plus point with immunotherapy.
So you also think the glass is absolutely towards full, it's not empty at all, right?
Yes.
Satheesh, what about you?
Yeah, I'll agree with Dr. Deepak. Yeah, definitely is adding our treatment option. I'll consider this immunotherapy option every patient, those who are affordable. But I can't say like it is a complete treatment, completely replacing all the modality of treatment.
Okay, fantastic. Yeah. By the amount of presence you have in BMS and MSG symposium, I'm sure you're putting everybody on immunotherapy. You're going to give Sevanthi a run for her money. Okay, Dr. Ramesh Purohit, from a radiation oncologist perspective, so what do you think when all your medical oncologist colleagues speak about immunotherapy? What is an out? I mean, I don't know. So, what is your perspective about that?
Sir, from a medical oncologist point of view, yeah, it is important. We are also, excited because of some trials of concurrent immunotherapy with radiation or some with adjuvant after chemo radiation. They have shown good results, and we are excited about at least concurrent chemotherapy and immunotherapy.
Everybody's excited. Fantastic. Dr. Kaushal has joined in. So, Dr. Kaushal, what is your take? Immunotherapy in lung cancer, hype or hope?
No, I agree with all of the participants. It's a hope actually, because the result of the immune therapy compared to the only chemotherapy is quite good, and the toxicity profile is quite bearable. So we can say that it's a hope.
Okay, next slide, please. So my take on immunotherapy in lung cancer is, next one. It doesn't matter if the glass is half full or half empty. There is always some wine to be filled on that. So it's a Saturday evening, and I like to keep it short. Next one, please. Okay, so that is why probably why everybody is saying about the hope over here, because 5 years survival in lung cancer 10 years back was hardly anything. I mean, there was no 5 year survivors in lung cancer around 10 years back. Next slide, please. And now, if we can see, even in a second line setting, the 5 year overall survival in the checkmate trials is a 15 to 16%, and in the first line is 24%. Next one, and next one, and this was the tail of the tail that we were speaking about. That 20% of people who respond are going to be long-term survivors. Next one, next one. So definitely, I think all of us are believers over here. There is no doubt about it. Next one, please. Okay, so now we just go on to the next one. So what do you think is the right place for immunotherapy in non-small cell lung cancer wild type? Suresh, I'd like to start with you. Do you think it's neoadjuvant, consolidation, immunotherapy, first line, second line? Can someone just move the slide here, please? Suresh.
Yeah, I think as of now, the evidence is strongest for metastatic first line as well as in second line. So in both these areas, we are sure that immunotherapy works very well in first line with chemotherapy Suresh, as well as single agent, and Suresh, in second line as single agent.
Sorry. Suresh, what I wanted to ask you was, so let's say a person comes to you for a second opinion. I have prescribed immunotherapy in first line along with some amount of chemotherapy. The patient doesn't really have that much of money. He says, Doc, is it all right that I start chemotherapy in the first line? And once I progress, then I'll take immunotherapy. Are you absolutely okay with it? Or you will tell him, no, you should take immuno plus chemo right now and take it further. What is your take?
Okay, in that case, I would say if the person is not very well off, and I would say that taking
What makes you,
immunotherapy in second
what
line
makes you
on
believe the
progression.
person is not well off?
Sorry,
What makes you believe? Okay, so the patient has been
you
referred to
you
you,
told
but
me there is an issue with the finances.
no, no, no,
I
no.
thought you told
Patient
me there's an issue with the finances, right?
patient is belongs to Dr. Sevanti's clinic. So
Okay,
the
okay.
I
Sorry.
don't think, yeah. So you better be okay. So
Yeah.
then tell me what is, leave the cost aside.
So in that case, okay, okay. Of course, I would first of all like to see what is the level of the PDL1 positivity. Also, that also sort of is taken into consideration for the decision. But so if it is more than 50% and the patient does not have bulky disease or very high level of tumor burden, I would say immunotherapy first line is the best option. With
Okay.
pembrolizumab is the best option if the PDL1 is more than 50%. And if the PDL1 is less than 50% or there is a very high tumor burden or bulky disease, I would recommend immunotherapy with chemotherapy as the
No, no,
first
that's
line,
okay.
especially
That's
pembrolizumab.
Suresh.
That
Suresh, one second.
so
I got your point. I just want to know right now we are discussing first line versus second line.
yeah.
Is everyone convinced that immunotherapy in first line is better than second line? That's what I want to ask.
Okay, so the important thing is that there is no head-on trials of immunotherapy plus chemotherapy versus only immunotherapy. Unfortunately, there is no such trial. But if you look at cross-trial comparisons or a meta-analysis which has been done, reviews which has been done, the comparative rates, if we see for PDL1 more than 50%, the response rates as well as the survival rates at 1 year or 2 years are comparable to single-agent immunotherapy versus immunotherapy plus chemotherapy. Having said that, if the PDL1 is less than 50%, we have seen that the results of pembrolizumab plus chemotherapy is very good in the patients who have PDL1 less than 50% or even less than 1%. There is a review of all the pembrolizumab trials where the trials have been combined and the patients who have PDL1 less than 1% have been taken in. Even in them, the overall survival benefit as well as the PFS is quite significant. So, in an affordable patient, I am convinced that immunotherapy plus chemotherapy would be the best choice if the PDL1 is less than 50%. Definitely.
Okay, fantastic. So first line, Dr. Deepak.
Yes, sir. Agreed. In an affordable patient, definitely, possibly PDL1, a combination of immunotherapy, pembrolizumab with chemotherapy should be the first choice if cost is not an issue.
Okay. I think by and large everybody believes that immunotherapy in the first line should be the way to go. Next one, please. So that's why the position makes a difference. Dhoni in sixth line at 6 wicket down. Next one. Versus MS Dhoni at number one or number two. That is what Chennai is looking at right now. So we'll have to see what I think. I'm convinced Dhoni should bat higher up the order, and I'm very convinced that immunotherapy should come higher up in the lung cancer treatment also. Next one, please. So we will start with this. Satheesh, this is for you. So you have a
Yeah.
70-year-old man who is a never smoker. He has a history of cough and breathlessness for 4 months. Stage 4 non-small cell lung cancer. So it's an adenocarcinoma. So how do you order all your tests? Just briefly.
Yeah, like the biopsy is already proven. Like I'll try to go for a molecular test. I'll try to go for a EGFR is the first this one because it's a commonly more expression is there. And next is ALK test and a RAS one and a PDL1. This is a sequence we'll do. But in our hospital, what we'll do panel at a time we'll send, but they'll do as a sequence. But we won't, yeah, they won't do all together. They'll do first EGFR, next ALK, like that. This sequence they'll do it, and then after that, those thing four or anything we are not got means we'll try to order some we require some additional thing is there we'll try to offer BRAF mutation like that additional
Okay.
mutation.
Okay.
Yeah.
Okay.
Yeah.
Next slide, please. And Dr. Kaushal, what do you do? Next slide, please. Dr. Kaushal, what do you do?
Yeah. I will do the same. EGFR, ALK, Roche, PDL1, and
Just
apart
stop.
from that, I would go for the RAT and MET also, and BRAF also, because we can have some BRAF inhibitors right now also. So
So how much time?
I
How much time does it take? I mean, that's what today patient comes to you. When do you
we
start
generally
treatment?
we generally advise the panel, as Dr. Satheesh mentioned, a lung cancer panel, and it will take around 15 days to come all the genetic markers.
Okay, okay, fantastic. So let's say the PDL1 has come as 70%. The EGFR, ALK, and ROS is negative. Suresh or Dr. Deepak can Dr. Deepak first, and then Dr. Suresh can take it.
So, sir, if PDL1 is greater than 70%, he is an elderly male, 70 years, though no comorbid illness. So, I'll like to check by which assay we have ordered a PDL1 testing. So,
Fantastic.
whether
22,
yes.
22 C3.
So it has been done to 22C3, then I'll be very much confident for this patient to give single agent pembrolizumab for this
So you
patient.
will get single agent pembrolizumab. So EGFR, ALK, ROS is negative, and
But also,
yes.
sir,
But
because he is a never smoker, so I'll meanwhile I'll order an NGS again. It takes a time for NGS detailed report that hotspot of multiple genes to come. So,
Dr.
but I'll
Deepak, I
start with immunotherapy.
agree with you. You will start with immunotherapy. Fantastic. Just go to the next slide, please. Suresh, the NGS report has come. One cycle of pembrolizumab has been given single agent, and if the report reveals either exon 14 or any BRAF or any HER2 or any exon 20 or any enteric fusion, what would you do? Patient has come to you for a second opinion.
Okay, any one of them, huh?
Any one of them, your take.
Okay. So
and I have given Suresh. Okay, so just remember, I have given pembrolizumab single agent. What would
okay.
you do?
Okay, so I would say as far as HER2 mutation is concerned, I am not very sure whether you have to stop immunotherapy. I mean, HER2 mutation per se in lung cancer, whether immunotherapy is less effective or not, I am not sure on that aspect. But as far as the other mutations are concerned, exon 20, exon 14, BRAF, NTR, BRAF and NTRK, we know that whenever there is a driver mutation, the efficacy of immunotherapy, even if the PDL1 is more than 50%, is not very good. So it is in that case, I would like to go for the targeted therapy after and stop the immunotherapy.
Okay, fantastic. Next one, please. I think our next one, please. Our time has been cut short by everything as in just been we are given 6 more minutes actually. So that's what Suresh was talking about basically, that anybody with an onco target gene has less efficacy. I for as a matter of practice, in a non-smoker, I would always order an NGS before giving a patient immunotherapy. Also, because yesterday we were discussing in another panel that the half-life of pembrolizumab will be around 21 days something, and if you give osimertinib or something after that, there's a higher chance of pneumonitis. So be very very careful before you start a patient on a single agent immunotherapy, especially in a non-smoker. I would, as a routine, order an NGS before we start him on IO. But then I work in Rajiv Gandhi, and our NGS reports can come back in 10 days time also. But that's just for education that we should try to do an NGS panel prior to that. Next one, please. Uh, Next one, I think we'll just skip this one. Next one, please. Next one. This was a blueprint study basically which showed. Next one, please. So let's say next one. I think we can go. So let's say the PDL1 comes as more than 50%, and the patient just next one. Just keep on moving it. I'll tell you. PDL1 is more than 50%, and so what are your choices? Can we go to Satheesh? So PDL1 more than 50%. What are the options that you have? Next one, please.
See, like if the driver mutation is not there, one of the immunotherapy one thing. If the one of the driver mutation is there, I'll try to go for one of the targeting
Yeah,
the
sure, sure,
driver
sure.
mutation. If then the other option is some of the patient not affordable for this IO, then I try to go for a chemotherapy. That's
Okay.
one of the option.
Patient is affordable. So what is your choice of treatment?
See, like
PDL1, this is the patient. You have a right lung mass with bony mets and soft tissue deposits. PDL1 is more than 50%, 22C3. What's your option?
Yeah, I'll try to go for the IO. Once I rule out that there no targeted mutation, driver mutation, I'll try to go for IO. Fit person, I say even like I know that even single agent quite enough. Even I can combine with even chemo also. Few cycle
Okay,
for 3 to 4 cycle, I'll chemo with immunotherapy. Then I'll try to continue immunotherapy in that cases.
fantastic. Next one, please. Next one. Next, next one. So, next slide, please. So this patient was started on pembrolizumab. Next one, please. Next one. Okay. Yeah. So let's say this patient was started on next one, please. On single agent pembrolizumab, and after 3 cycles, next one. After 3 cycles, the PET scan report comes as this. If you can read this report properly, it says that the lung mass has slightly reduced, the lymph nodes has slightly reduced, but there are some new bony lesions which have come.
प्लाज्मा नहीं चाहिए ना, मैं क्या कह रहा हूँ तुमको, समझ रही क्यों नहीं हो?
Dr. Shyam Agarwal. Okay. So let's say so how do you now proceed? So Deepak, can I come to you? So single agent
is patient symptomatic, sir?
No, patient's PS is same. Next slide, please.
Okay. So sir, if patient is asymptomatic, then I'll continue with the single agent pembrolizumab.
So my
reassess after three cycles.
Fantastic. So everybody agrees, Dr. Deepak, Dr. Suresh, Satheesh.
Yes.
Yeah, I'll agree. I'll continue and reconfirm the disease progression. If oligo one site is increase in the lesion.
There are multiple new deposits of multiple new body deposits which were seen.
Yeah, asymptomatic, I'll continue pembrolizumab and try to reconfirm by again the second imaging. Then if it show the document, then I'll try to change the thing.
So let me be the devil's advocate and say, can I add the option number B? Can we continue pembro and add pemetrexed carboplatin? What do I lose?
So, sir, patient will become actually, if it is a toxicity that is causing now the symptoms, so that will be difficult to decide. So, I think at this point, continuing with single agent pembrolizumab with patient is asymptomatic.
Actually, Shivanti से मेरी बात होगी है. Hello.
Can I request all the non-pharmacists to Dr. Kaushal Patel?
Yeah.
So what would?
Yeah, if the patient is not symptomatic and only the bony disease, then I will continue pembrolizumab and not try to add chemo combination in that particular setting.
Fantastic. Next slide, please.
Ullas will try to the tendency to have a chemo like this. Definitely trial setting, they'll try to reconfirm in the second image, then only they'll try to do. And we don't know, even if you like chemotherapy added, whether chemo has made a changes, really that whatever you are giving immunotherapy is working or not, then we'll be simply we're continuing chemo with immunotherapy. We are wasting a lot of money. That's why if you're reconfirming the second image progression, then definitely take a definitive decision.
So Satheesh, you read the PET scan report right now. After 3 more cycles of single agent pembrolizumab, that says that the body lesions have become stable, but the lymph nodes have now increased. And if you feel like hitting someone, there is a better option, okay? And I'm just going to stop now after this. So what will you do now?
I'll try to like see like in this situation I'll try to add additional thing along with the immunotherapy with the chemo or like antiagenic drug. Any one of the options I'll try to do.
Okay.
Or I try to have symptomatic is there, I'll try to have SBRT to that along with the like some lymph nodes or I can try to give that single localization. Yeah, there's various options I can try to.
Dr. Deepak, what will you do?
Sir, again, if is the patient symptomatic right now?
Patient says patient says some pain is there, but he's reasonably okay.
So, sir, again, after discussing the option that this may be a progressive disease on immunotherapy, I'll like to still continue with single agent pembrolizumab. And if there is a symptomatic deterioration, I'll be closely watching for it. And then subsequently, I'll confirm it as a progression and then I'll stop immunotherapy as a whole and I'll start with chemotherapy alone subsequently.
Okay. And what about Dr. Kaushal Patel and then Dr. Suresh? And that would be my last slide.
Yeah. If there is a progression of the disease in form of the lymph node, then I would like to commit with the significant progression is there. And if it is the progression, then definitely I would like to stop the immune therapy and would consider for the chemotherapy, second line option of the patient.
Okay, Dr. Sevanti, we have done NGS for this patient. The NGS is negative. So Suresh, what would you do?
So I think there was some discussion on adding chemotherapy to this immunotherapy. So is there any evidence of adding chemotherapy midway to immunotherapy? And so I have a lot of discussion on this
But
line.
it's
So I
very
don't know if there
tempting.
is any evidence on these lines at all.
Radiation
No.
evidence is there.
Tempting.
Radiation. There is a data is there for adding radiation to that area.
We can add. As you mentioned, correct.
That's
We can give targeted therapies to what you call the locally progressive small lesions and try to continue with immunotherapy. That is one option. But the most my take would be that a small lesion which is not causing much symptoms, I would like to continue with immunotherapy for as long as it is beneficial, with a very closer follow-up, probably a CT scan every 2 to 3 months to check for progression, because we have seen that these small lesions progress very slowly while on immunotherapy, and patient continues to derive benefit for a long time. And if there is a significant progression, of course, we would change to only chemotherapy.
Fantastic. I think I have been told by the organizers to stop right now. But what I wanted to bring out through this case was an actual real case which we routinely face in the tumor board. And honestly, 60% of people actually start chemotherapy and add it on to immunotherapy. There's a lot of noise coming up. So with this, I think I'd like to thank all my panelists for a wonderful discussion and hand it back to the organizers. Thank you.